Thank you everyone for joining us for the final session of Rev Up 2021. I'm Ryan Schonecker, SVP of Sales and Marketing at Icario, and today's panel session is called Small Steps to Big Wins, SDoH interview of health equity, digital divide, and other hot topics. Before we jump in, just a reminder for those of you who joined before, please use the Q&A feature as opposed to the chat as you're asking questions, and we'll be going through those. There'll be a question and answer session at the end, but we'll be seeing that and looking through and making sure we're answering those as we go. Also, as a reminder, for those of you on Twitter, we'll be live tweeting the event. The hashtag is #RevUp2021. So please join into that as well. And there's going to be a brief survey as you leave the session today. So please give us feedback and improve so we can take a look for improvements for next year. And then lastly, we are recording today's session. So that'll be available on revupshow.com. And with that, I'm going to turn over to today's moderator, Sara Ratner, to introduce us to the panelists. Sara?
Great. Thanks, Ryan. So I'm Sara Ratner. I'm the SVP of Government Markets and Strategic Initiatives here at Icario. And with me today are several very distinguished individuals. The first is John Gorman, who's the chairman of Nightingale Partners. Second, Andrey, who is a practicing physician and managing partner of Social Innovation Ventures. And the last is Michael Calogero, who's the Chief Growth Officer at GA Foods. So thank you for joining me today. So I'll tee up the conversation in a broad sense around SDoH. So John, this one's for you. There's been a huge focus by plans on social determinants of health. And as you know, there's a ton that is happening in this space. Can you talk to us a bit about some of the more innovative initiatives that are taking place? Especially, stuff around the digital divide, maybe?
Sure. It's really an exciting time to be in this space right now, Sara. I mean, there's a virtual arms race going on among Medicare Advantage and Medicaid plans in how they're gearing up to address social determinants. There's certainly a lot more activity and investment going on among the big nationals, but we really are starting to see some interesting movement in the middle market and among the regional players as well. I'm a very strong believer that, the margin is in the marginalized and especially in the most marginalized. And so all the innovations that I really kind of see out there that really catch my attention really deal with some of the toughest to reach populations that there's out there. The most recent one that I really noted comes from my dear friend Sachin Jain at Scan Health Plan. And I think we may have all read the news a couple months ago that SCAN is actually starting up a special mobile medical group for its unhoused members in Southern California. And I just thought that's just a brilliant idea. There's so much that can really be done to intervene with the unhoused, short of permanent housing, where you really can let the perfect be the enemy of the good. There's still a lot that can be done, and having a mobile medical group for the homeless just struck me as a really brilliant innovation. I was really encouraged this year when I saw a very little noticed benefit among some Medicare Advantage plans, most notably Anthem, where they're now covering in most of their markets pest control, as well as an allowance for home modifications to reduce fall risks and to improve indoor air quality. So, just the focus on pest control is just brilliant, because you've got so many conditions among the low income, like asthma, or COPD among elderly people that are exacerbated horribly by indoor air quality. And the biggest contributor, obviously, is cockroaches and mold. So, really being able to actually have money from your health plan to be able to afford pest control and home modifications is brilliant. And I'm, in particular, most interested in what underpins all of our investments at Nightingale are really three things. Broadband internet access. We realized a year ago that we were unable to reach upwards of 50% of the people we were trying to intervene with just because they're not connected to the internet. So we went on a crash course to invest in a broadband company and are really bringing them to bear now. We are seeing with one client, a 2,400% increase in engagement in telehealth and remote monitoring adoption by patients just by wrapping around the new EBB benefit from the FCC and providing them with devices, additional minutes or broadband access, and then importantly, the digital literacy to know how to use those devices once we have them. Second is community health workers. They are the foundation of everything that we do. And we're seeing some really interesting movement among some of our portfolio companies around putting together a national staffing agency for community health workers that we're really excited about. And then, of course, food security is really where it's at. And I'm going to wait to hear Michael's comments on that, because there's nobody better to hear that from today.
Thank you, John. One of the fundamental flaws with digital health, where a lot of us specialize, is those who need it most don't have access to the technology or the minimum upload and download speeds that are necessary in order to even access telehealth. So that really resonates with us, John. And speaking of technology, Andrey, how are organizations leveraging technology to advance new social determinant of health initiatives?
Maybe I could back up just a quick step.
Yep.
To point something out that I think is often overlooked, which has nothing to do with technology per se, and that is that I think you're putting this in the context of supplemental benefits and Medicare Advantage, but we often don't talk about the fact that so many of these Medicare Advantage beneficiaries are at a low enough federal poverty level that they actually qualify for nutritional benefits as well as other types of benefits that otherwise get put into supplemental benefits for MA, but could in a much less expensive way be serviced through existing safety net programming like SNAP benefits or dental, vision, hearing, transportation benefits. And that's a really important consideration in terms of like the healthcare, the cost of using supplemental benefit dollars versus using those other safety net programs. And there's a bunch of them. I think that if we're going to do innovation correctly, digital innovation or otherwise, let's better utilize and enroll Medicaid. Let's better utilize and enroll in Medicare savings program or low income subsidy program, or as I mentioned, SNAP, or some of the like low income home energy assistance program. Like these are all SDoH focused interventions that have been around for some time, that are very effective at poverty alleviation, but that MA plans get too wrapped up around, oh, let's be innovative, use supplemental benefits, which is way less expensive if you just enroll the folks into those programs. Having said that, as John is referencing, like there's has to be a sensitivity to the consumer journey. And if an individual who has Medicare and is at least eligible or nearly eligible for Medicaid, the first thing when they wake up in the morning is not how can I get access to a cool new app or how can I digitally engage. They're thinking about, one, they're anxious because they're lonely and no one's around. They're worried about, are they going to get enough food that day? And they're kind of terrified of falling and what happens if they fall and they lost dignity, or the fear of loss of independence, because what if they can't drive anymore? What does digital have anything to do with that? What does an app have anything to do with that? I think apps can support that, but mostly in the service of augmenting human to human interactions. And so technology enabled services for the most part are where I see value being created for these populations. In some cases, pure software plays can be super interesting. I take this with a grain of salt. I'm an investor in a company called Uno that is like back-end processing to optimize eligibility and enrollment in some of these programming for duals. There's fraud, waste, and abuse plays that are super interesting that are pure software, but all that is like really back-end. If we're talking front-end, patient-facing or Benny-facing or provider-facing, software is not the trick. It's software enablement of services. And as all of us on this call have discussed many times, that the real differentiation is who is going to build empathy the most and who will be able to not have the cogs of a technology outweigh the potential of a tech-enabled service business to become profitable. That's the magic. And those folks that are able to figure that out are the ones that are going to win, create value for the bennies, and not create unnecessary waste in the system at large.
That totally resonates with us, Andrey. I mean, especially, with the remarks that John spoke about around community health workers and just the real importance on those individuals who can help this really underserved population and helping them augment these other care avenues and programs that they can take advantage of. So one of the things that we speak a lot about, we meaning, most people on this phone call, is food and food insecurity. And it's such a big issue because it is kind of the gatekeeper to so many other healthcare problems that we see. Michael, you are an executive at GA Foods. You guys are pioneering some great work in this space. Can you tell us a bit about how GA Foods is impacting these programs and how you're working with health plans or providers?
Yeah, sure, Sara. I think I really agree with what John and Andrey were speaking about. And we see, it's interesting, we see the business in so many different markets because you have funding coming from so many different places too, which is actually enlightening to see, considering, I mean, in 2021, we estimate about 45 million people in this country will have some type of food insecurity, which is just mind-boggling, actually. And we look at the business on the health plan side as to what we're focused on. Our business is kind of in two ways. It's interesting. We started out as a family-run business 48 years ago in the community, just serving, 8 people, in the simple way where you have areas of aging and kind of the senior population. And now you see this complete evolution over many decades now to where we are, but there hasn't been massive improvement. I think on the managed care space, we see really 4 major segments. There's a post-discharge coming out of hospitals, which is a fairly just basic benefit that most people don't even know that they have. And I think going back to Andrey's point, it's interesting that, where you can actually place some of those dollars too for more needy people coming out of hospitalization and stuff like that. And then another key area for us is chronic condition, right? So everyone's looking at, and there's some good studies with backing ROI around diabetes, CHF, end-stage renal disease, even fall prevention. We have a major focus in maternal health because it's, as we know, unfortunately, Medicaid moms are 3 times the cost of a commercial mom in this country. And there's just a variety of reasons that contribute to that. And we're trying to offer more beyond just food there. But of course, LTSS, the long-term services and support, I mean, that's $1 billion industry that's funded through managed care, let alone what's not funded through, just non-for-profits and just, kitchens and churches and everything else. And then, of course, supplemental benefit is the one that just is evolving at a rapid pace, not only in the MA side, but we see a tremendous amount of really velocity in the area of the DSNPs, your chronic special needs plans. So that I think you will see just this, I think just an evolution that will go very, very quickly. When you look at all the other 15 supplemental benefits and how they've evolved over years, I can't imagine how fast nutrition and food will be. But I think it's not just about nutrition and food. I think what we would all echo, and how do we get engaged with those members? And what I'm usually saying to plans, it's interesting, is as you're offering a benefit or funding something around food insecurity, what else are you looking for around social isolation, which is just, it's really, that's number one, interestingly enough, right now, post-COVID, in terms of a social issue, and financial insecurity, which just tie, hand in hand. And to echo what John mentioned earlier about Anthem, it's interesting as an example, you're talking about even, just having, just a pet, they're basically saying, here's $500, you pick the benefit that fits your need. And I think that's what's been really enlightening to see, is where health plans are starting to say, everybody's a little different. And how do we kind of fit the need that we have the dollars, but let you take it as almost an allowance to figure out what you want to do with it.
Michael, you spoke a little bit about post-discharge access.
Mhm.
Can you say a little bit about the role that, geography, affordability, and even knowledge, what role do they play in food insecurity?
Yeah, it's fascinating to me because we have, of course, provider-led plans in the country too that are taking up this idea of managing their own members that are coming out of the hospitals and that's pre and post surgery if you really think about it. Certainly, the amount of folks that are sitting in nursing homes and long-term care today is much less than it was 2 years ago, and that's playing an interesting impact here. So the discharge even out of nursing homes is a prominent space for food and allowing people to get meals. So to really kind of look at that from even a rural standpoint, we know that there's a tremendous amount of consolidation, right, that's happened in the acute care space, and because of that, you're hopefully allowing more resources to get into some of these rural areas. But there's no reason why I'm surprised when I see Dollar General that has 15,000 plus stores that they're getting into helping people with food insecurity. And it's not hard to kind of drive around some places that you would see, okay, they're the only place in town. And it's as we've seen, like with a Walgreens or CVS or any of these stores, how do you get access out to the people instead of bring it out to them? And I think that that's what you're going to see a little bit more in some of the innovation.
Let's pivot a bit and talk about data. John, these programs, there is a ton of data that's being generated, and plans are collecting a lot of the data. And what I find is it can become overwhelming on how to actually use it. John, what are some ways that plans can leverage this data to actually create actionable insights to implement these new programs, and where should plans start? That's what I find difficult at times.
Yeah, absolutely. I mean, I think we all know that the volumes of data that plans have at their fingertips is really just noise unless you can make some sense of it all. I'm sorry to have to say, Sara, I think we got to kind of start at basics. I posted on LinkedIn a couple of weeks ago about how appalling it was that so few health plans even know the race and ethnicity of their membership. I mean, it's like over 94% of commercial plans, 50% of Medicare Advantage plans, and almost 30% of Medicaid plans don't have any race or ethnicity data on their membership. That's just appalling in the year 2021. There's absolutely no way that you can get started with any kind of coherent social health strategy unless you've got basic data on who your members are, like, are they Black? Are they white? Are they Hispanic? And then ethnicities within them. I mean, the way you would structure an intervention for an African American population as opposed to, say, a Haitian American population is going to be very, very different in approach. So first, you got to kind of start with knowing as much as you can about your membership. And then you got to go a lot further. There are very few analytics vendors out there that are really doing the necessary social analytics to really be able to structure an accountable and sustainable intervention on almost anything in the social health space. On every one of our projects, our due diligence process involves looking at over 5,000 sources of publicly available data before we even can determine if there's an investable social health opportunity there. So, a lot of analytics vendors are stopping at basic demographic stuff. You need to go a lot further. You need to be looking at who's had their homes foreclosed on, who had their car repossessed, who checked into a homeless shelter in the last 2 years, who checked into a food bank in the last couple of years. That's all publicly available information. Who's just coming out of the criminal justice system. All that stuff you gotta have in order to do the necessary hot spotting or geographic analytics that tell you where is the greatest concentrations of folks in greatest need. And then to be able to start to slice that population into, okay, here we've got maternal and child health issues among women of color. We've got rampant diabetes across this entire service area. We've got about 20% of these folks who are severely transportation challenged. We've got 10% of them that are utterly housing insecure. And we've got 70% of them that are food insecure and need a whole lot more, as Michael was talking about, than just food benefits attached to an episode of care. They need a regular delivery of food, one, just to meet basic nutrition, but especially if they're diabetic. So data is absolutely critical to doing this stuff right. And frankly, to be able to structure the kind of experimental designs that enable us to demonstrate that these programs are successful and that they are yielding results. Because as you know, as the business is with CMS or state Medicaid agencies, if you can't prove it, it didn't happen. And so much of this stuff is going to be driven in star ratings and in Apple ratings in Medicaid right now. And if you don't have the data to demonstrate that you're doing what you promised you would do in your contract, you're going to be in serious compliance trouble, much less not hitting, basic clinical quality and cost savings goals of these types of interventions.
It's interesting to me, we've been studying credit history. And if you look at credit history, it's a greater predictor of your health than probably your healthcare experience. And so it's this need to take an outward in approach rather than an in to out approach, and trying to figure out the likelihood and potential issues that a member is going to have. Michael, I'm curious, what data do you guys collect to prove the efficacy of your programs?
Yeah, it's a good question, Sara. There's certainly NPS scores, right? And when we look at NPS scores, we're looking certainly at our, food quality and taste and all that stuff. But it's also, at the same time, since it's more real-time kind of information we can get back to the plan, we're interested in giving them some information, like, does the member appreciate, for lack of a better term, the benefit that they're getting? Do they understand it, how it's used? And what if they need additional benefits? Like, that's an important question that it's almost a little too open-ended, but we do ask it at times because we see, especially on our LTSS side and the Medicaid plans that we're working with, because 25% of even the post-discharge market is Medicaid. We're asking that type of a question because there's a lot of community resources that we can connect people to that need more help beyond their benefits. So it's, the plans are leaning certainly on federal and state funds, which they certainly can, but they're moving into their benefits. So the other data points that we're very interested in actually providing information around, especially if you look at just post-discharge as one example, is what's the readmission, risk, because they just got out of a hospital. And so we're trying to get a little bit more data in 834 files and different profiles of those members to understand, like, subpopulations, comorbidities and stuff like that, multiple conditions. And then how do we drill down a little further into that, profile to understand what types of questions we can ask. And then gaps in care, of course, is an obvious one, that if we can get that information back to a plan in real time, that's critical. In the chronic space, it's, very specific. CHF, we can go further into a lot of interesting places that track some areas. But what we're trying to do is kind of a full health engagement. So we want to stay connected to that person even after their benefit. We can teach them how to eat well and be better when they have CHF or diabetes, but how do we kind of continue down that path to stay connected and then get information back to John's point earlier? It could just be around social isolation, or we see financial insecurity just to be a complete a barrier, right, to anything.
If we think a bit about efficacy, it's really important to understand the value of these initiatives and the impact on the populations that are targeted. And there's a tremendous value in funding these initiatives and supporting them. However, Michael, you guys have done a great job in trying to prove the value. And Andrey, I want to turn to you for this. How are you seeing the industry respond to the need to prove out efficacy and program success around these different programs and structures?
I believe that the view of ROI and SDoH is overly siloed relative to the bigger picture of the beneficiary. investments in SDoH have been shown to have a net positive ROI. The challenge is that their time horizon to reach net positive ROI can be longer than the average churn of a member. And so it becomes a little difficult for plans, especially MA plans, and really, especially Medicaid MCOs, to make an SDoH investment that a competitive carrier is going to benefit from. Having said that, I think that plans need to move away from a myopic view of what exactly is the unit economic of a specific SDoH intervention, and instead focus on the more longitudinal view of that patient. But that may be wishful thinking, because most plans are incentivized based on quarterly performance, and they have this very narrow view and short-term view. I do believe that those plans that are serving duals, especially those sister Medicaid MCOs to D-SNP plans that have to compete in state RFPs, increasingly they need to show their longitudinal effect. And I think there's an incredible amount of leverage that state Medicaid leaders that are writing these RFPs can exert on how plans design their benefit structures. And the final thing I'll say about data and SDoH is that a lot of risk adjustment gaming that's been happening has really been entirely been focused on medical complexity. There's a recent OIG report that honed in on just how acute the problem is with MA plans gaming HCC coding. What's interesting is that there is no accountability for social risk factors in coding, and other than like indirectly dual status where the premium will be adjusted. I think it would be absolutely fascinating to incorporate social risk factors into risk adjustment, and as part of that refresh of risk adjustment payments, minimize some of the loopholes that allow for upcoding without any actual improvement in or change in the quality of care that's being delivered. So,
John, what are you seeing in this regard? And I think one of the things, Andrey, that you said that I'm really curious about is we, as an industry, started marching down this path of trying to capture social determinant of health factors as part of a medical record through Z codes. And there's been a big push to risk adjust around it. John, what are you seeing? I mean, to me, you must have tremendous insight into this and what's happening.
I think because we're investor backed, I mean, we have to measure the hell out of everything we're doing. On every project that we go into with a plan, we've got multiple KPIs for that are tailored to that specific intervention and population that we're going in with. So say if it's a broadband intervention, Sara, which is a favorite of yours and mine, we're looking at adoption rates. We're looking at data volume. We're looking to see, are there kids in the home that are actually able to use the service as well for their schoolwork? We're looking at rates of connectivity and participation in telehealth visits. We're looking at adoption and uptake rates of remote monitoring devices in the home that can be used. And then, of course, on every one of our interventions, we're taking a baseline of what that member cost before we started in with the intervention. And then we're measuring that annual cost of care annually so that we can assess how much the intervention's actually saving the health plan. One of the reasons we love investing in social determinants of health, as I said at the top, it's like the margin is in the marginalized, and you'll never see better returns as an investor than in some of the stuff that we get here. It's also worth pointing out, Sara, that we are way beyond this stuff being experimental in nature. I mean, there's some new benefits that are out there. Like we're still figuring out how to manage to measure the effectiveness of a pest control benefit, say. But there's just scads and volumes of research out there about what community health workers provide in terms of a return on investment. I mean, they are routinely shown to save $2,200 per member per year for every member that they engage with. You see staggering rates of savings that you get from housing unhoused people, as you would imagine. One of the things that made me want to be a healthcare investor was the incredible results that Geisinger got with their diabetic meal delivery program for their seniors. I mean, when they started out, they were paying almost $250,000 per member per year on their uncontrolled elderly diabetics. And then once they started a diabetic meal program for them, in under a year and a half, they had that average cost down to $49,000 per member per year. So they saved a net of $192,000 per patient per year. And that's a 35x return on investment. So I think it's really important that you have a combination of KPIs and other baselines that you're taking at the outset of these engagements, and that you're measuring those things regularly, longitudinally, as Andrey spoke to. We have to do that because our investors are, Republican billionaires, and they're standing behind me, tapping their foot saying, John, what's our money doing today? But look, any payer is going to want to know, especially their chief actuary, what are the results that we're getting for this investment, for this putting this in the bid or an SSBCI, or doing it as an off benefit plus for those who need it most. I think it's critically important that you can't improve what you can't measure.
Yeah, I agree wholeheartedly around that. If we look forward, Michael, you are living this every day, how to deal with food insecurity and food access. And I think COVID has certainly thrown, a wrench into how we're trying to address it. Some of us can afford Instacart or Shipt, and that's a very difficult barrier for people who can't afford just basic necessities, or at the end of the month have to live on donuts. So if you think, going forward 5 years, what will the industry look like? How does this play out in healthcare programs and the benefits that are offered?
You'll see more and more results, right? I mean, we know that we have quality indicators clinically, right? So we can look at A1C results for diabetes. We know how to do it from a medical side, and we know everything there. What's interesting is the National Quality Forum is probably maybe one of the better spots where you can kind of start to look at ROI as it's tied to social determinants of health, and we kind of rely on that as at least the barometer to what we're trying to do and prove out. I mean, what we're seeing though with national plans and even just regionalized plans is about a 20% reduction in ED use, right? So emergency department. And then you're also seeing about that same 20% reduction in just overall cost per member, kind of a per member per year type of model. And that's not just involving chronic conditions. You have to certainly have the engagement part. So if we're not going to have the people engaged in some way that is well beyond just text messaging or something like that, it's just more of that very specific engagement on the data piece, then we won't see the same results. But what's exciting, Sara, is that we now are actually seeing the managed care world, especially, understand that it's obvious that any social determinant, of health and any supplemental benefit that we can offer is going to play an impact to people's actually health costs, which is just not maybe something that we all thought about maybe 10 years ago, right? And it's certainly now in play. And so we're pretty excited to see what will probably be in 3 to 5 years, a market that will have probably doubled to 2.5 times.
Great. It needs to. And I would hope it would be more than that.
I wish I was as optimistic about Michael on anything beyond food security in terms of uptake. I mean, while there's definitely an arms race going on among the big nationals, there's astoundingly low uptake on SSBCI among plans. I mean, it's appalling to me that here we are 5 years into this, and only 19% of the plans are participating in any way in the special supplemental benefits for the chronically ill. Now, among the biggest increase, of course, in year over year was meals beyond an episode of care, as Michael spoke to. But then also, like, my God, you saw a 568% increase in the social needs benefit. Home modifications are up about 380%. But it's important to recognize those are such huge increases because we're starting from such a small end. There's just so few plans that are still, aware of and pursuing the value of these types of benefits and interventions.
Yeah, and two quick points to John there. I think I agree 100%. What we're seeing, some of the shift of dollars is away from SSBCI in the supplemental benefit. So it's kind of like, hey, we have so many comorbidities amongst our membership that we're just going to give away it in the supplemental benefit space, which doesn't help everybody, which is probably where you're aiming towards. And I get that for sure. And Sara, back to your point, even a little bit about COVID and the impact, it's staggering to kind of look at a statistic that around 2011, somewhere around there, we were at about 15% of households had food insecurity as one example, and it went down to about 10% over 10 years, and literally in 1 year went right back up to 15%. So you talk about a crazy amount of impact of as we talk about like how jobs and the economy and all these things will get back and takes time. Think about like what just turned around in 1 year. It's amazing, sadly.
Yeah, I agree. You guys are talking about supplemental benefits versus SSBCI. John and Andrey and Michael too, if we take a step back, how are plans funding these initiatives? And the other thing I also hear quite often is like, is it, for MLR purposes? Is it a medical cost? Is it an administrative cost? And some back and forth around that. Can you guys speak a little bit about how plans are paying for this and how you're seeing it play out?
Yeah, just a quick note. I mean, the plans always prefer to make this go under the MLR as part of their medical spend. They try to avoid as much as possible putting it into administrative spend. Kind of hard stop there. One thing I will note, just to the last question about like the next 5 years, we're already seeing a significant amount of consolidation in the SDoH space, with Unite Us making its now second acquisition in a short period of time. It may not be long until they get a third acquisition. And I think the general space of SDoH solutions is the blending of those directory services with what is much needed but not existing as managed service organization type of functions for community-based organizations. In other words, how can CBOs that have no financial wherewithal to capture the value that they're providing to the system financially, and is there an entity that'll be the middleware to distribute those revenues to CBOs that rightfully deserve them, and then also elevate CBOs' technical and process capabilities to make the most of what they're doing. I think that will lead to some very interesting payment questions to this immediate question that you're posing, Sara, and I think that's a really big innovation opportunity.
Agreed.
John, what about you?
Well, plans pay for this stuff to the extent that they're doing it through a variety of means, Sara. I mean, if you put it in the bid and it's in SSBCI or it's in supplemental benefits, it's covered. We tend to like to do our stuff off bid and outside of the benefit structure because we like to really be able to target our interventions just to the folks who need it the most. I mean, about the only time we do it on bid and as part of the benefit design is with a dual SNP, when literally everybody enrolled in the plan needs what we're doing. So we like to do this stuff administratively so you can target it and not have to make it available to everybody. And obviously we are a source of third-party capital to help defray the costs of some of this stuff. You've got, other sources of capital. You've got the Opportunity Zone program, of which we're a part of, and some inner city plans, especially Medicaid plans, are starting to make some use of that program and the tax shelter that it involves if you invest in these disadvantaged communities. There's about $100 billion in social impact bonds that are engaged in the US every year now. Some small portion of them are going into healthcare for interventions and programs such as this. There's still an important role for philanthropy in some of this. But I think at the end of the day, what a lot of us are really hoping for is that we'll see some legislation or regulation in the next couple of years that would allow whatever investment plans are making in social determinants to be included under the medical loss ratio. I mean, these are fundamentally initiatives that are about improving quality and the cost of care. And that's literally the definition of what belongs in a medical loss ratio. And I think that would really encourage much greater investment by the plans and third-party sources if that was the case.
Yeah, I agree 100%. Michael, what about you when you're having these conversations with health plans? Do you get into how plans can fund this? Is it admin benefit or profit?
Yeah, we do. Yeah, it's exactly what I would echo what was just said. I think what's interesting is that the amount of dollars that you're talking about for some of these costs around any of these benefits is so small compared to other areas that are on the medical side. It's not even close. But so if a plan's really interested in helping their diabetic population, for an example, it is a challenge sometimes to explain to them, like they're asking us for, well, what's the ROI on that? And I'm like, all right, well, there's plenty of, there's some good studies out there that will show that, and your peers are also doing it. I think some of to John's point, I think earlier, some of the national plans that are out there will probably, as usual, lead the way in some of the areas, and it will be more regionalized or by state, and other local plans will follow suit to be competitive. But the funding is really, we're seeing a little bit, and we're willing to entertain it, a risk type of value-based kind of contract. So we could say, hey, if you don't believe in the ROI, which is clearly in some of these studies, then we're willing to kind of to do not only say, food and nutrition, but also therapy, like dietitian therapy, telehealth, and also some other engagement, and then prove to you that not only will you reduce some of your medical costs, but also some of the improvements we can do around unplanned type of costs or gaps in care and stuff like that. So if you can do that, then I think some of the plans are a little bit more, I think, open to it. You just have to prove the data on the back end, so you can kind of get rewarded a little bit for what you're taking share and risk on.
I love that. I think, putting your money where your mouth is
Sure.
such a great idea, and really helps demonstrate the value to all of the different participants in the system. We are close to the end of time. I know we have 15 minutes and we wanted to open it up for questions. Ryan, I'm going to turn it over to you for questions.
Yeah, great. So we've got a whole bunch that have come in. I'll try to combine a few as we're asking them here. So there's a few along the lines of what did the federal stimulus packages or employment benefits that the federal government's been providing, how has it impacted any of these programs, whether it's food, housing programs, or other programs in both positive and negative ways?
Don, you want to take that one?
Sure. Well, there was quite a lot that was in the first couple of COVID relief bills, but the really big stuff is in Biden's infrastructure package. That's the Hill is at war over as we sit here talking. There was notably in the stuff that we work on was the launch of the emergency broadband benefit at the FCC, which provided about $65 billion to help defray the cost of broadband and internet access for lower income folks. So that program will take $100 a month off your cable bill and allows you to have access to devices if you need them for health reasons, which I thought was just a brilliant program. There was some pretty considerable increase in the community development block grant that came through it, which helps fund programs like Meals on Wheels, which was certainly critically needed during the pandemic. And as Michael pointed out, we've seen hunger increase dramatically, so that now 1 in 7 Americans is now technically hungry, which is just disgusting in the richest nation on earth. And there's just, so many line items in there that were kind of helpful to the social determinant of health cause, if you will. But man, really all the big money is in this infrastructure package. I mean, they're looking at hundreds of billions of dollars for home and community-based services. I mean, if I can encourage anybody on this call to expand your alphabet soup repertoire, I would start remembering HCBS, because that's going to be a huge area of investment for the feds in the years to come. And similar programs like that. So, I mean, there's just so much in these two bills. I mean, it's evident that one of Biden's top priorities was health equity, and you're seeing it in all this legislation. I'm sure Andrey's got a few others in there that he really loved too.
Yeah, the only one I would add is the provisions available to non-expansion states to have a Medicaid-like program, which would pretty meaningfully close the Medicaid coverage gap. And along with that, you have all of the benefits of the Medicaid program, which includes investing in social determinants of health directly and indirectly in a pretty meaningful way. And as always, just Medicaid expansion alone, if we were to do anything, just do that. And that's going to be the most efficient taxpayer and societal ROI out there.
With the Hunger Games that are going on up on the Hill right now, as they're trying to take this thing down from a $3.5 trillion package to something less than half of that, that exactly what Andrey's talking about, the Medicaid expansion for red states that have pointedly refused to take the greatest deal ever made by the federal government to states, would absolutely be the most impactful thing going. And that they forget about, pulling Medicaid coverage away from the, what is it, 15 or 17 million people, Andrey, that got it during the public health emergency. I mean, that's right there. Those are the two biggest steps that this package could make to advance health equity. And I certainly hope as much of it will survive as the Democrats can muster a vote for.
One of the things that I've noticed is with the infrastructure bill, especially the emergency broadband benefit, I don't know if you guys have tried to go through it as kind of a demo, but it is very difficult. And so I think there is an opportunity for healthcare innovators to get in front of this, to say, how do we make it simpler for people to actually take advantage of it? There's like 7 hops you have to make along the way, and stand and turn on your head and do all these different things. It's like magic. So to the extent that we can help solve that problem, it will make the ability to take advantage of these benefits just that much easier. Ryan, what else do you have?
So looking at some of these, we talked about ROI and kind of timing around it. What are some other KPIs that people are using today for kind of looking at the success of these programs? If the time horizon, as Andrey mentioned, is a little bit longer than the turnover rate within Medicaid, what are some other KPIs that people should be looking for as they're setting up programs?
Michael, do you want to take that one?
Yeah, sure. I can take a shot. They're definitely looking at utilization. That's going to be a tremendous area for them. And I think just also engagement. It's interesting. It's when you look at like maternal health as a different example right around this, their engagement is so important to the overall success of mother and baby. So as they offer these types of benefits, some of their KPIs are always going to be structured around my engagement and interaction and ongoing interaction. They can give as many incentives as you want to people, but that doesn't necessarily mean that they're going to use it in the right way. So I think that measurement to take the data to a new level is really a critical area that I think many times the plans are smart enough to see down the line, and then kind of make a vertical for that. The other area I would just say that when you kind of think through funding again, the USDA and kind of what they've done lately is tremendous. And that was, I think, more a result of kind of farms to family and just different programs that have come out there that you'd be surprised as sometimes what's happened in some of these regional areas and these food deserts or food swamps, however you want to call either of those examples. But yeah, I think that's how I would probably answer some of that.
Just a follow-on question, and this is for any one of you. When plans offer these programs, do you see a corresponding increase in their member satisfaction and stickiness?
Yeah, I mean, I'll take it real fast. I mean, I think I would say, you can have an NPS score of some of these health plans that if they're, at if they're at 30, right, they're pretty maybe happy. And then all of a sudden you see within a benefit that they could be up to 70s and 80s. And it's just an amazing, part to it. I think taking that to another level, though, again, is not just saying, hey, I'm giving you something for free. Of course, you're going to like it. But what did it do to that person's daily life, the weekly life? Like, how did it impact them in other ways? I think is really important too.
Oh, there's no question. And especially when you consider that what most plans would tell you is that the biggest drag on their star or Apple ratings are low income people, and duals especially. You see outsized impact to CAP scores from launching these types of programs. Especially, and obviously this is, the name of the game in any social determinant of health intervention is adoption, and getting the member to actually know that this is available to them and then actually use it. But once you do, man, there is nothing more impactful than having a community health worker helping you daily figure out what you need to do to stay healthy. There's few things that have greater impact than a consistent meal security benefit that's not attached to an episode of care that you can rely on. But I'll tell you, man, I've never seen satisfaction numbers go up faster than when you provide them with broadband internet access. That's just an absolute home run. And, to be able to do that as we were doing furiously during the summer and the run up to open enrollment, I'm sure it's also going to have a big increase in member retention and in getting some new members as well. But those NPS scores go through the freaking roof when you offer broadband. It's awesome.
Yeah, I think of it, if I have a little sticker on my broadband that says, whatever name of the health plan, that's a pretty good way to keep that member and avoid them losing their broadband access. Ryan, what other questions do you have for this group?
Another one, there's a few questions around SDoH diagnostic codes, or just Z codes in general. How and when should people use them or not use them? How do they know when to do that? Right.
Andrey, you're smiling, so I know you can take this one.
There's been documented peer-reviewed literature, and in our experience, that those codes just are not getting used. There's no incentive for providers to use them. I can tell you, when I'm on service and I've got a busy service, I may be, a standard deviation away from the mean, but I click like the least number of ICD-10 codes possible, click a CPT code, and get the hell out of the EMR and go back to patient care and actually seeing humans. I think even those providers that are around the mean, that are trying to be diligent about capturing all the ICD-10 codes, there's a lack of awareness of the Z codes. And then even if they've participated in some CME activity educating about the Z codes, why would a doctor go through the extra click to document housing insecurity? It doesn't impact their care, it doesn't impact their revenues. So why do it? There are some folks that are leading the charge, like Corinne Van Zandt over at CareSource, that had a really big push to financially incentivize providers to document ICD-10 codes. But it took heroics. Corinne is a doer. She convinced her colleagues at CareSource to go and create a financial incentive. But that's kind of, I think, a demonstration of a market failure if you are having a separate financial incentive to change provider behavior just so they code differently, as opposed to providers having, let's say, a fully capitated model where there may be a risk adjustment benefit for capturing complexity. That would be interesting, or something thereabouts. So we have a long way to go until we get there. I'm really glad the Z codes exist, but they're necessary but not sufficient in capturing, quantifying, and then actually acting on SDoH issues.
Anytime you can make something in terms of even, just reducing admin cost. I mean, as someone out there is trying to provide to health plans and such, admin costs can be significant costs, not just for them, but for any vendor too. So to cut through some of that stuff, I think is important to do if we can. And the easier way that we can place a barometer around the social determinants and not make it as complicated as ICD-10, would be great. I don't think that's the place that our system needs to go. I think there would be a lot more fraud and abuse, and we can only imagine. So.
Absolutely.
With that, I'll just say thank you very much for joining us. Thank you to all our panelists. Really appreciate the great insights. A lot of people have been asking about where to find the recording. Again, that's going to be at revupshow.com. So check that out. We'll probably have it up, I'm guessing, by tomorrow. And be on the lookout. This is the last one of RevUp 2021. We're changing the name for next year, so be on the lookout for Trailblaze 2022. We will see y'all then. And thank you again for your time today.